Hi, everyone. Thank you so much for joining us here today for our innovation webinar. We are very excited to welcome Dr. Cornelius James to give a talk about preparing for a clinical world that includes artificial intelligence, tools, teammates, and teaching. Dr. James obtained his medical degree from Wayne State University School of Medicine and completed a combined residency in internal medicine and pediatrics at Beaumont Health, where he served as chief resident in his final year of training. He is a primary care physician practicing as both a general internist and a general pediatrician at the University of Michigan. Dr. James has held numerous educational roles across the continuum of medical education. He has successfully revamped evidence-based medicine curricula for both the University of Michigan Medical School and the University of Michigan Internal Medicine Residency Program. Dr. James also contributes his expertise to several local and national committees. Locally, he is currently a research member of the Michigan Medicine Clinical Intelligence Committee. Nationally, he currently serves on the Macy Foundation Artificial Intelligence Medical Education Artificial Intelligence in Medical Education Steering Committee, as well as the International Advisory Committee for Artificial Intelligence. Dr. James is also a member of the Academic Medicine Editorial Board and is co-editor for the MedEd Portal AI collection. He leads the Data Augmented Technology Assisted Medical Decision-Making Team, a multidisciplinary group that has developed web-based curricula aimed at preparing learners across the continuum of medical education to critically appraise AI and integrate its outputs into clinical practice. His research also focuses on the equitable implementation of digital health technologies, including AI-based solutions into clinical practice. We are very excited to welcome him today. If anyone has any questions, please enter them into the Q&A section, and Dr. James will answer them after his talk. And with that, I will turn it over to Dr. James for his presentation. And thanks so much.
All right. Thank you very much for that introduction, Ashley. I really appreciate the opportunity to be here. Appreciate Ashley coordinating things and Dr. Gambari reaching out and asking me if I'd be willing to present. And when I think of Dr. Gambari, I think that we previously lived like literally a few steps away from one another in the same subdivision. I've since moved, but I appreciate our prior interactions when exiting and entering the subdivision. So I'll go ahead and get started. I do not have any disclosures. And what I'd like to do is start with a case. And what I want to do is ask you to imagine that you are a cardiologist at a health center. For many of you, I'm sure that's not difficult to do, but imagine that you are a cardiologist at a health center that specifically recently implemented an AI system called Echo Go Pro. And this algorithm was designed to predict a person's risk of coronary artery disease using images from a stress echocardiogram. And at the top of your list of images to review on today is Mr. Johnson's. And Mr. Johnson's a 62-year-old who presented to his PCP a few weeks ago or so because of a history of substernal chest pain, mostly occurring while he's lying in bed. And he's also experiencing a rapid heart rate whenever that happens. But this pain tends to resolve without any kind of intervention after about 30 minutes or so. So continuing our case, Mr. Johnson does have a history, family history of coronary artery disease, and that his father had a myocardial infarction at 57 years of age. And Mr. Johnson himself, he quit smoking about 2 years ago after smoking 1.5 packs per day for about 20 years, but he doesn't have any other significant past medical history. EKG's normal, other labs, other testing that was completed related to this was normal. So Echo Go Pro categorizes Mr. Johnson's risk as high probability for prognostically significant coronary artery disease. So, but you conclude that there are no findings concerning for coronary artery disease. So what I'd like you to do is consider briefly what you would do, or maybe if not what you would do, perhaps what you would suggest that your resident or your fellow or medical student do in this particular situation. And if you'd like to enter what you would do into the chat, certainly feel free to do so. But just think about, again, Echo Go Pro. It is designed to diagnose coronary artery disease using stress echocardiogram images. And the particular model here, the Echo Go Pro, has identified Mr. Johnson's images as being concerning for, or predicting that Mr. Johnson has a high risk for coronary artery disease, but you tend to disagree, or your resident fellow or student tends to disagree after reading these images. Just again, think about what you would do. Maybe you go to UMGPT, which I'm sure many of us are familiar with, and you just simply ask or put in the prompt, can Echo Go Pro accurately diagnose coronary artery disease? And you get this response back that it's a software product developed by Ultramics that uses AI to analyze echocardiograms and assist. It's also designed to assist healthcare providers by providing insights and measurements from heart ultrasound images. And this Ultramics, as some of you may know, they've developed other products. For example, they have developed a model that is capable of predicting a person's risk of heart failure with preserved ejection fraction and or identifying people who could potentially have a cardiac amyloidosis. So Echo Go Pro is just one of the algorithms within that suite that could potentially be useful. And I say that, with some skepticism, and hopefully you do the same. So perhaps, the output from ChatGPT is not all that convincing or it's not all that helpful. So you decide to look to the literature. And you come across this 2022 study here that shows that, and this study included both it was a development or training and testing or validation of the Echo Go Pro model. And it suggested that, it can fairly accurately diagnose severe coronary artery disease. And you take another step further and you see that when we want to determine whether or not this actually improves a clinician's, when you want to determine whether or not it actually improves a clinician's diagnostic accuracy when it comes to identifying coronary artery disease on a stress, findings concerning for coronary artery disease on a stress echocardiogram, you see that there is this improvement. And the AUROCs there at the bottom, I believe that is a typographical error on the part of the journal. But basically, what you could see here is that those who read the echocardiogram or the echo images without the assistance of Echo Go Pro, they basically have a lower AUROC or lower diagnostic accuracy relative to those that actually do use the technology. So I again encourage you to think about what you would do in this situation. Or perhaps this changes your mind or it influences you in some way when you see that in December of 2020, this particular model received FDA approval it received marketing authorization. Would that change your mind? But I want to specifically point out here, though, that within the letter that they received in relation to their FDA approval, it stated that it's not intended for assessment of mild or moderate myocardial ischemia or localization of CAD or for assessment of myocardial viability or valve disease. So kind of reading in between the fine print. Still, we got FDA approval, but at the same time, looking at the fine print a bit more, you could see that maybe not necessarily for everyone that we come across when we have some concerns about potential CAD. But then you also see another study. If that, perhaps the FDA approval wasn't super convincing, so you want to do a little bit more digging, and you come across this RCT that randomized clinicians to either using Echo Go Pro or not using Echo Go Pro. Now, notice that this is NEJM AI 2024. The prior study that I showed you was 22, but this actually received FDA approval back in 2020, right? So this has actually been deployed in some hospitals, both in the UK and the US. So multi-center RCT randomized to either standard decision-making or AI augmented decision-making. And in this study, they did not meet the pre-specified non-inferiority margins, but they did show that perhaps this model is effective at institutions with lower stress echo volume. So again, I just encourage you to kind of think about what you would do in that particular situation. And perhaps this kind of lets you know or allows you to appreciate that, at least on its surface, there is the potential for these models to be a bit more, or to be shown to be a bit more accurate and or effective or useful in some situations when they actually may not be. One other thing I wanted to just sort of point out here is that you can see radiology and or image-based specialties when it comes to AI that's where we're seeing a lot of momentum, so to speak, where you can see that radiology specifically, when it comes to FDA approved AI models or AI systems, there have been over six. This says like 692. There's been over 1,000 now. This was back in 2023, but you can see here that radiology makes up 76.9% of the models that have been approved, or medical AI that's been approved by the FDA. And then, second, and pretty far behind, but still second, which I think is notable for this group, is that cardiology is second at about 10.1% of approvals. And I'll also point out that when it comes to um, top medical AI procedures and adoption based upon CPT code use in insurance claims, you can see, it's diabetic retinopathy, liver MRs, but then also coronary artery disease or coronary atherosclerosis are the top procedures that people are billing for that are related to medical AI. So with all of that, or with that introduction, I just want to encourage you to think about, that kind of progress that we went through when it comes to, a study or a model, an artificial intelligence system that was kind of in disagreement, or perhaps we'll say you were in disagreement with the model. And then there's literature out there that suggests that a model is more or less effective. And then there's also FDA approvals out there that we have to consider. And so with that said, I encourage you to think about what skills will physicians of the future need as we are inevitably going to and continue to deal with AI, and or I should say benefit and leverage these technologies in an effective way. So I have a few objectives that I'd like to meet today, and I'm hoping that by the end of this presentation, you'll be able to appreciate the historical evolution of healthcare AI, and also summarize the current state of AI integration into clinical reasoning curricula, because that case that I gave you earlier was certainly a clinical reasoning case. And then lastly, recognize some initiatives designed to begin preparing clinicians to integrate AI into the clinical decision making. And with that said, I typically start these presentations with sort of the why. I know there's a lot of talk out there about like AI and its role and the potential impact that it can have on the patient-clinician relationship. I will say that my work is it's done, or the things that I'm doing, it's ultimately done, with the hope that AI, or leveraging AI, teaching clinicians to leverage AI, to use AI in their clinical practice, will allow them to develop a closer, stronger relationship with their patient, and not to have AI replace clinicians. Certainly, I do believe that AI will replace some of the tasks that clinicians currently perform, which I believe could be a great thing because it allows us to interact with our patients and develop stronger relationships with them. But ultimately, the goal is that we can, and I'll show this in a slide a little bit later, but the goal is to, again, strengthen that patient-clinician relationship. So a lot of my work has been initially, or at least early on, it was focused on this National Academy of Medicine report published back in 2015. And the report is titled Improving Diagnosis in Healthcare. And one of the goals identified in this particular report was to enhance healthcare professional education and training around the diagnostic process. And they specifically noted to also include training on how to use health information technology in the diagnostic process, and then also that clinical reasoning and also teamwork there as well. So that led me to sort of look back and kind of think about how we have been doing when it comes to clinical reasoning and or diagnostic reasoning in curricula. And you can see in this 2017 paper, when a group of clerkship directors were surveyed about their perception of students' understanding of clinical reasoning concepts upon entering the clerkships, you could see that, when it comes to different concepts or skills, clerkship directors rated students basically in the poor to fair range for the most part upon entering clerkships. So not doing that great. And then when it came to their perception of the importance of teaching clinical reasoning topics and their current coverage of clinical reasoning topics in the internal medicine clerkships, you can see here that only estimation of pretest probabilities was rated as only more than 50%, or 50% or more only rated estimation of pretest probabilities as currently covered. So all of the other content or topics, you can see that there were no more than 48.8%, and that's for likelihood ratios That's the next highest thing or next most frequently covered subject in the clerkships around or in covered in the clerkships in internal medicine clerkships. So you could appreciate that, our students are not getting much, and I won't say that that's the case for the University of Michigan only, but this is a representative of a national group of clerkship directors. But you could appreciate that, we've got a lot of work to do when it comes to teaching these concepts. And then back in 2020 or so. And now keep in mind again that report that I mentioned was back in 2015. So here we're seeing some experts in diagnostic reasoning describing some competencies for improving diagnosis and using an interprofessional framework here. So here they describe 12 competencies, 3 domains, and describe some foundational concepts and some desirable attitudes that clinicians should have or should be developing if they're going to effectively engage in the diagnostic process. And again, this is 2020, right? So I graduated from residency in 2015. So we're talking about only 5 years ago where we started to really, now certainly if we know that we've been thinking about these topics or these subjects or concepts for longer, but kind of formalizing them, you can see that it's only been since, about 2020 that we've started to develop specific competencies around this topic. So that same group described what this process could look like. They described some foundational literature, described a new field back in 2019. So this is even a little bit earlier, but a new field of diagnosis education, right? So it doesn't seem like it was that long ago. And they also mentioned diagnosis technology. And given the subject of our talk today, I encourage you to think about where AI fits within that. When it comes to synergy with other educational movements, again, diagnostic technology being amongst those education movements, and more specifically AI. But will we be here? Is AI going to have such a significant role in healthcare, in our clinical decision making, that it should be a part of that foundational literature? So if we're going to consider the diagnostic capabilities of AI, I think it's very important that we consider human diagnostic reasoning and what that process looks like. So to do that, it's important to consider concepts in cognitive psychology. And I'll describe some of those concepts in a little bit. But when we talk about diagnosis, we're talking about ultimately the context within which that diagnosis is occurring, the knowledge that a clinician possesses to engage in, or that would allow them to effectively engage in that diagnostic process, and then also their experience with a particular situation that they may be facing when it comes to a potential diagnostic dilemma. So many of us are likely familiar with this dual process theory, where we talk about, there's often the reference to thinking fast and thinking slow, or this intuitive versus analytical reasoning, or this pattern recognition versus probabilistic thinking. I think this is important to consider because as we think about AI and its role, we also have to think about our teaming with, or our collaboration with, diagnostic AI. So does diagnostic AI go through some of the similar processes, or use some of the similar pathways that are similar to the pathways that we use when it comes to diagnosis? And then also, is it subject to some of the potential biases that we tend to be subject to as it goes through that diagnostic process? And how can we potentially pick up on one another's blind spots, so to speak? How can we augment one another, meaning the human and the AI, as we engage in that diagnostic process? That also, we also must consider calibration and uncertainty. So as clinicians, as we are faced with various diagnostic or management situations, if we are aware of the outcome of that diagnostic situation or that management situation, we are going to calibrate. So if we are aware of the outcome and we know that it's unfavorable, then we will likely recalibrate and make changes so that we don't hopefully make that same diagnostic error or commit that same diagnostic error. But if we have a favorable result, or if the result is unknown, we tend to maintain or continue to do what we typically do. And the same could be true. Again, I encourage you to kind of think about this and how it relates to artificial intelligence And not only artificial intelligence alone or humans alone, but both humans and artificial intelligence together. And then there's also the uncertainty piece, right? So we know that much of what we deal with, it's not often 100%. And the same is true when it comes to AI or artificial intelligence, right? We talk about a lot of probabilistic reasoning where or there's probabilities or many of the things that or many of the outputs that AI will generate are based upon probability. So just sort of thinking about how we as humans and as AI, as we kind of come together and as we're facing these diagnostic dilemmas, what will that look like? And as I move this through this talk, you'll be able to see what that could potentially look like. So another goal in that National Academy of Medicine report was to ensure that health information technologies support patients and healthcare professionals in the diagnostic process. So this was again back in 2015, and they did mention in that report that though relatively early in development and application of new the application of new computational methods such as AI and natural language processing has the potential to improve clinical decision support. So they did acknowledge that, but they clearly were not as far ahead as we are now back then. So tools and technologies were certainly included within that work system of the diagnostic environment. But I believe that those tools and those technologies are going to move closer into the middle here and actually become part of the diagnostic team. So with that said, I want to provide an operational definition of artificial intelligence because that's what we'll cover for the remainder of this talk. And I'm going to just use a very broad operational definition of artificial intelligence, and that'll be it involves the use of computers to perform tasks that require objective reasoning and understanding. And as I'm sure you know, there are various domains. There's also narrow versus generative or more general AI. And Howell and colleagues published this paper in JAMA describing these three epochs of artificial intelligence, where we went from a more probabilistic models in the 50s or so. And I show you this because it's important to kind of recognize that AI is not new. When ChatGPT came out in November of 2022, I'm sure many of us know that is not when AI was invented, but that's when it certainly increased significantly in popularity. And then you have this 2.0, which is deep learning, and then the three includes the foundation models where we see generative AI. And in this paper by Kara, it's published in a cardiology journal. They described those three epochs and went into a little bit more detail. And what I want to do is just provide a few examples of these tools. So these are diagnostic tools here, and the D-Explain and the Internist one and the Mycin. These were models were developed fairly early on. Now, amongst these D-Explain, it is still used mostly for educational purposes, whereas others like Mycin, that is no longer used. And a lot of that is because these models can't really accommodate, or they don't account for the real life clinical practice that we're facing, the uncertainties, right? When you talk about these rules-based models. So this is more of that rules-based phase, but then we move into the deep learning phase where we see it's task specific, right? Or unimodal tasks. So the AI has been developed or designed to perform a specific task. And this is an example. This is a landmark paper of an AI that was developed to specifically diagnose skin cancers on cell phone images, right? And it had great performance, but again, it's unimodal, task specific. And these models are still important. And I'll also say that the cardiology model that I showed you earlier, the Echo Go Pro, that's within this sphere as well in that deep learning. And here's another important or landmark model that showed that a deep learning model could autonomously diagnose diabetic retinopathy on retinal fundus photographs. So again, we're still in that task-specific unimodal phase. And that's where a lot of my work clearly started. And again, that's up until November of 2022. So we then move into Epoch 3, where we have these foundation models, where these models are capable of performing various tasks and even using or doing never before seen tasks, right? So we're not talking about that limited, more narrow AI. And you can see that since November of 2022, as I'm illustrating in this image here or in this figure here, that there have been a number of large language models and or generative AI models that have been developed. Some of them now specific to medicine and or healthcare tasks or trained on things like many people have used open evidence, which is it uses retrieval augmented generation, and it pulls in articles from open access articles, titles and abstracts, et cetera, from the web, right? So we know that we've like Chat GPT, it's trained on a large corpus of data, but not generally or typically healthcare specific, although it can be used for healthcare reasons, but with caution. So here is an example of a paper, a study that was done by folks at Michigan, and this is just to sort of show, like AI, it has a lot of potential, but there are also some things that we need to consider as we use these technologies in our clinical practice. So this is a study completed by folks here at Michigan that show that clinicians' baseline accuracy when it comes to diagnosing whether or not a person has like pneumonia or COPD or heart failure based upon a X-ray, a chest X-ray photograph or chest X-ray image, their accuracy at baseline was 73%. And then when you use a standard AI model, an AI model that was trained well, you see that their performance, their diagnostic accuracy actually increases with explanations, and then it increases even more, or it increases without explanations, and it increases even more with explanations. But then when you bias a model, the investigators here intentionally provided a biased model, and without explanations with that biased model, you can see that their performance went down. It was much lower, right, compared to even their baseline at 73%. And then with explanations went up a little bit higher compared to without explanations, but you can see here that the performance still was much lower compared to where they were at baseline, and certainly much lower when they were assisted by the model. So this led to questions around the issue with potential automation bias. And it led me to sort of thinking about how much vigilance are clinicians going to have when it comes to these technologies? How much are they going to have to know about these technologies when it comes to using them within their clinical practice in diagnostics and for other reasons? And then we all may also be familiar with this study here, again, Michigan-based, that showed that this epic sepsis model, which was broadly deployed, including here at Michigan, showed this study here externally validated. So it actually looked at it, how this model was performing at Michigan, and they observed that this model was not as accurate as was reported in the literature by Epic. And not only that, but you can see there's lots of alerts there. And the question is, how helpful or harmful are those alerts? And what does that do to a clinician's trust and or confidence in these models when they're engaging with them and they don't tend to be very accurate? And this is another model. This is a study published by Obermeyer a little while ago, just showing that the potential bias in models, right? So there are issues that need to be considered when during development of these models, and if they are not considered, it could potentially lead to bias. And in this particular example, there was a program that patients could be referred to if they were deemed to have higher healthcare needs. Now, in this particular case, white patients interacted with the healthcare system more, and therefore they incurred more healthcare costs. So the model determined that the white patients were likely to benefit from this particular program, whereas the Black patients in this study, while they were sicker, they did not engage with the healthcare system as much, and therefore they were not their score on this particular algorithm was not high enough to warrant or where they would it would be suggested that they be referred to this program. So again, just imagine an awareness of the potential biases that are involved, and this is again in a model that was deployed in a healthcare system. So as we think about that, it's going to be important for us to think about the continuum upon which we are going to interact with or engage with these technologies. So in some cases, certainly AI is going to assist us in diagnosis or clinical reasoning or other tasks. but in other cases, it's going to be automated. But I suggest that regardless of what occurs, the patient and physician autonomy must be maintained. But that's going to be dependent upon the amount, in my opinion, the amount of education and understanding. Not saying that every clinician or physician is going to need to be an AI expert, but to understand some of the risks and benefits, to understand or appreciate the right questions to ask when using a model or when engaging with the technology is going to be very important. So that our team, a little while ago, we published this paper in Cell Reports Medicine. It was a commentary. And here we described teaching AI as a fundamental tool set of medicine, where it is as fundamental as a learner learning how to use a stethoscope. Because believe it or not, the stethoscope at one point was considered a new technology, right? But teaching it so that it's as fundamental as the history, the physical exam, and so on. So some have developed some competencies very similar to the competencies that I mentioned around diagnostic excellence. Some have developed competencies around what the competencies that healthcare providers or health professionals should have when using AI in healthcare. And one of the competencies that they mentioned that kind of stood out to me, and this is partly because I direct the evidence-based medicine curriculum here at the medical school, was the evidence-based evaluation of AI-based tools. So we're talking about assessing or critically appraising these tools, critically appraising the literature, being able to identify and determine whether or not there are biases that exist within these tools that would make it so that I should think twice or perhaps not use a model at all. So, my belief is that because we're seeing this to some extent now, when it comes to teaching these competencies, if we were to think about like a medical school or a graduate medical education curriculum, I've identified a few places where I believe teaching this content could be helpful. Now, at the undergraduate medical education level, health system science has a larger or greater footprint. So that's a place where, at least in UME, the content could be taught. But certainly when it comes to clinical reasoning and decision making and being able to explain the impact that these tools will have on that process, that's another place within curricula where it could be taught. And then clinical skills. And then lastly, the evidence-based medicine, as I mentioned earlier. So that led me to think a little bit about evidence-based medicine and what this is, and actually thinking about how I'm teaching evidence-based medicine. And it also led me to sort of reflect on evidence-based medicine being another or an earlier paradigm shift, even before the paradigm shift that we're seeing with artificial intelligence. So, they defined evidence-based medicine as and this is Guyette and colleagues, they defined evidence-based medicine as the integration of best research evidence with clinical expertise, patient values, and preferences. And they ended up developing these users guides that you may be familiar with. Now, this text is a little older now, and the last edition was 2015, but it serves as the standard textbook for many medical schools across the country. And you may also be familiar with these pyramids. And this AI has caused me to sort of rethink what these EBM pyramids look like when it comes to the levels of evidence that we and our learners are engaging with. And then we talk about this like 6S pyramid, which includes these various levels all the way at the top with systems. And in the past, that was very much considered a futuristic level, so to speak. But when it comes to the single studies, some have proposed that this is what it's going to look like now in an AI world, right? Where we have that background and expert opinion and so on. But then even like deeper than that is going to be all of this data that we have coming in because of the use of things like sensors and wearables and so on and so on. So it's going to cause us, or it should cause us as clinicians, to consider data and or evidence from various places now, as opposed to what we're traditionally seeing. So again, it's caused me to sort of rethink what EBM could look like. Yes, certainly including integration of best research evidence, clinical expertise, patient values, and preferences, but increasingly it's going to include the outputs of AI and ML. Very similar to that case that I showed you earlier when it came to that cardiologist that was viewed those echocardiogram images, but they also had to include within that the outputs of that AI. They didn't have to, but they did in that case, right? So how does that impact the decisions that we make, right? So I mentioned that user's guides to the medical literature that was published. Again, latest edition was 2015. Back in 2019, there was a paper published around or related to reading articles that use artificial intelligence or use machine learning. There was a user's guide related to that. So, we are seeing some improvement when it comes to preparing or we're seeing some initiatives when it comes to preparing or teaching clinicians to engage with this literature. We have a long way to go when it comes to actually teaching learners or clinicians, both practicing and in training, to engage with these technologies. So this brings me to the work that I've been doing, which is this data augmented technology assisted medical decision making team. So that's a team that I have the privilege of leading, but certainly benefiting from the expertise of wonderful people, many of them included here. So our team includes librarians, medical educators, medical students who are MD, PhDs, working on doing machine learning work, house officers. Andrew Wong is now a National Clinician Scholar. Nurses, computer scientists, engineers, lawyers all came together to develop curricula. Well, this is our mission here, to develop, implement, and disseminate innovative healthcare AI and ML curricula that serve as a foundation for medical educators to develop curricula specific to their own institutions and or specialties. We knew that we were not going to take a one size fits all approach, but instead we had to develop curricula that were fairly generalizable, that could provide some information about foundational principles that educators could eventually build upon themselves. So what we initially did was we worked with the National Academy of Medicine. They provided funding for us to develop a curriculum with that included 4 online modules, and this was all focused on diagnosis. And we used the EBM framework and Bayesian approach to kind of teach this content. But you can see here, the modules included topics on intro to AI and ML in healthcare, foundational biostats and epi, using AI and ML to augment diagnostic decisions, ethical and legal use of AI and ML in the diagnostic process. And then, so we integrated portions of this curriculum into the internal medicine residency program. So we had interactive small groups and didactics. And we did a pre-test, post-test, and retrospective pre-post. I can't share the data with you at this time, but I'll just let you know that we noticed statistically significant differences in residents' knowledge and attitudes around using or appraising the diagnostic AI literature. And these are some of the specific objectives that we used with that curriculum when we talked in day one, in the intro to AI in healthcare. It was basically very foundational, lots of didactics. The same is true for session 2. But on day 2, we really dived in, and the learners went through a clinical case, appraised literature related to that clinical case, and had some discussions around the evidence supporting use of that technology. In this particular case, it was related to skin cancer, using a FDA-approved skin cancer model, or a model designed to diagnose skin cancer, and then talking about some of the potential legal and ethical ramifications or considerations around using that model. And again, this curriculum, well received by the residents. And again, I'm fairly confident that this will be published in academic medicine fairly soon. We also worked with the American Medical Association. We went broader, beyond diagnosis, and we developed 7 web-based modules that described not only diagnosis, but went into more detail on the methodologies, prognosis and treatment, AI in the health system, law and ethics, and precision medicine. And again, each of these curricula were developed with that team of folks that came together. So it wasn't just me. I am not a developer of these technologies, but I am an educator, a clinician, and we all came together, for the purpose of developing these modules. And it was very interesting to collaborate in this way, because we were able to sort of appreciate or benefit from that collaboration, given that there were there was various expertise that was extremely, again, beneficial. So then this is the AIM-PC curriculum, and this is becoming a bit more specific in that we worked with the Society for Teachers of Family Medicine, and this was funded by the Gordon and Betty Moore Foundation, to develop 5 web-based curricula that were primary care specific. And this includes a video series, and this is being launched in phases. This has not been fully launched. We've launched about two of the modules thus far, and a number of videos that includes innovators with interviews with innovators from around the country. So people from Emory and UCSF and so on, just sort of describing the importance of these technologies in clinical practice that will allow people to sort of have an understanding of the importance of beginning to engage with them. So that meant much of our work was around narrow AI, meaning task-specific AI. But I mentioned ChatGPT being released back in November of 2022, and since then, we've seen lots of papers published out there related to generative AI and how it performs relative to, say, medical students or practicing physicians or residents in performing diagnostic or clinical reasoning tasks. And in many cases, the AI performed very well. But what I'm thinking we need to do is, and I think we're seeing this increasing, and I'll show some literature to show that we are doing this more. But thinking about this, not from the perspective of, or through the lens of what AI can do and what it's going to prevent humans from doing, but thinking more about augmented intelligence and how these technologies can potentially augment what we do. That's not to say that there are not some tasks that AI will perform better than we do as humans, but thinking about how we relate and or collaborate with one another as teams. And this means that in some cases, AI will certainly serve as a tool, but in other cases, it may certainly serve as a teammate. And I mentioned here that this is going to lead to a changing in identities, roles, responsibilities, and it's going to ultimately be a paradigm shift that'll lead to some changes in clinicians' professional identity. So this is a study here that many of us are likely familiar with that showed that when physicians using GPT-4, and this is, I'm going to use quotes here, air quotes, and say relatively older study because it was only like 2024 or so. But you can see here physicians using GPT-4 versus physicians using conventional resources like UpToDate. There was not a statistically significant difference between those two groups. But when it came to GPT alone versus physicians using GPT, there was a statistically significant difference in that AI performed better alone relative to physicians. And I'll say AI compared to GPT-4, it's even more powerful now. I won't go into a lot of detail about that, but it's even more powerful and will likely perform even better. And this is another study performed by folks who performed the prior study, but this is looking at not just diagnostic reasoning, but management reasoning, so treatment and testing decisions. And in this case, there was a statistically significant difference between physicians using GPT-4 and those using conventional resources. There was a statistically significant difference. But in this case, GPT alone, there was no statistically significant difference between GPT-4 alone and physicians using GPT. So this is, again, for those management reasoning and or task or management or treatment or testing decisions in relation to clinical cases, performance on clinical cases. I should emphasize that this is not real world clinical practice, but instead clinical cases. So again, it just makes me think about this triadic. This is a paper that colleagues and I here at Michigan published related to what the team is going to look like. And in my opinion, this provides a framework for what this is going to look like when it comes to clinicians interacting with AI and patients interacting with AI and those groups coming together. So we'll move away from a triadic patient clinician team to we'll move away from a dyadic patient clinician team to more of a triadic team that includes the patient, AI, and the clinician. And this is going to lead to important decisions around reskilling and upskilling and deskilling and automation bias and so on and cognitive offloading. But this is what I believe is the reality of clinical practice in the very near future. So that's led me to, again, reimagine what I do when it comes to the evidence-based medicine cycle. I have not implemented this. I do in the medical school EBM curriculum. I do have a session in there related to AI and ML, but it's not nearly what the learners need in order to effectively engage with these technologies. But, prompting is going to become very important, and teaching the students, to prompt using chain of thought prompts. PICO will still be important, but it's just a reimagining. When it comes to literature, choosing the appropriate large language model and obtaining useful answers, appraisal of those outputs, determining whether or not the output of that technology is relevant to my specific target population. And then I mentioned that human AI collaboration, and learners are going to have to evaluate and refine their performance of this newer EBM process that they'll be engaging in. So a few take home points. Hopefully you could appreciate that we are still very early, surprisingly, in teaching clinical reasoning skills, which is even more challenging because now we're adding, we've added evidence-based medicine in there. We've also added AI into this. So hopefully I'm not overwhelming, but you can clearly see that we've got a lot of work to do because there's lots of focus on these different domains, but somehow we're going to have to bring them together to ultimately ensure that clinicians are being prepared to effectively take care of patients in a real world clinical setting. It's going to be important for us to understand this human AI collaboration, in reviewing current content and figuring out or determining where we're going to be able to integrate this content specifically related to AI is going to be really important. And then I also wanted to just mention that there are folks out there doing this work. We recently released some recommendations around integrating AI into health professions education. That QR code there will allow you to access that. And then if you are working on anything education related where you have taught your learners to use AI in their practice, development of a formal curriculum, I've had the honor of serving as a collection editor for the AI collection for MedEd Portal. And then we also have for the Macy Foundation, we've also generated some recommendations that will be released in the relatively near future in a couple of months or so. So we are thinking about it. I know I presented a lot of information that kind of suggests, okay, what do we do and where do we go from here? But I did want you to know that there are folks that are out there thinking about this, and I am fortunate to be one of those. So I will stop there with this quote from Osler related to medicine being the science of uncertainty and the art of probability. And I see that as especially relevant as we talk about AI or these technologies. So I'll pause there, and I'm happy to answer any questions.
That was amazing, Cornelius. Congratulations on all the hard work. And, we're so fortunate to have you here as a leading voice and expert in this area, really. I wanted to ask you a couple of questions. My first question was more a philosophical, like medical education question. What are your thoughts around credentialing and board certification when, I can look and I can pretty much ask anything from an LLM and it will answer it? Like, what's the value of that? And how are you thinking about that and the importance of that when you're like selecting residents and going forward with things like that?
Yeah, so broadly, I'll say this is going to change. I mentioned professional identity formation, and in my opinion, this is going to change the folks that we recruit into various specialties. And in some respects, that could potentially already be happening in specialties like pathology and radiology. But as we rely less upon rote memorization, because AI is going to perform a number of tasks that we perform that often require rote memorization and so on, and you can recall that in medical school or in residency and in various places. So knowledge will always be important. The key is going to be knowing what knowledge we need to know. But in my opinion, the days of the quote all-knowing physician being the one that stands out, that may potentially go away in the future. But the physician that's able to effectively engage with patients, that's able to team with colleagues, to collaborate with colleagues, that's able to critically think, and certainly knowledge is necessary for that critical thinking, but that's able to think critically, that's able to effectively communicate. Those are the physicians that, in my opinion, are going to really stand out as top-notch physicians. And that's not dismissing the importance of knowledge. Now, when it comes to what this is going to look like on board exams, so there's a health system science shelf exam. It's not used very often by medical schools, but there's a health system science shelf exam, and there is AI and ML content there already. And many of the meetings that I participate in, so the Macy meeting and other lots of other meetings that I with the AMA, I was able to participate. The National Board of Medical Educators, the American Board, people from the American Board of Pediatrics, internal medicine, all of those folks are at these meetings. So it's coming in that, and we know that there's often that delay too, when it comes to new practice and new, new things that that are out there in the literature, but it is eventually coming. And they are aware of this paradigm shift. But the question is, how do we make that shift, or what does this look like? And I don't think anyone has that answer at this point, but it is coming.
Yeah, no, I love how you laid that out. And it's kind of, I guess we're all kind of like trying to figure this out as we're going forward. Uh, you mentioned this, I'm trying to think of how you describe the best way of describing it is that like when I'm trying to think of myself like when I was a resident now many years ago, where like, majority of my task was kind of like getting information from different resources, putting it together, think about discharge summary, make sure that the patient that I'm ordering a medication can afford it, they have the social support there. And what you're describing, I think, is kind of like this unbundling of all the tasks. And right, so you imagine an agent doing discharge and one agent doing pharmacy. Uh, what's left after you unbundle are like what would you advise a new resident as you can imagine that all those tasks will be unbundled. What is left and what should they focus on going forward?
Yeah, so I love that question. The first thing that I will say is, you know, what you described just sounded so wonderful to me. Now one of the things that learners will have to do, and these technologies are going to become better. And so I have the privilege of being one of the ones piloting DAX co-pilot here at Michigan. And it's great, but it makes a lot of mistakes. So there has to be that vigilance there when residents are engaging with these technologies with their, say for discharge summaries or patient portal messages and so on. But perhaps these technologies allow the residents to go and sit at the bedside with patients more because they're no longer doing as many of those discharge. It doesn't take as long to do those discharge summaries or some of those other administrative tasks that are very important, but perhaps they are able to improve their auscultation, or their like, a cardiac auscultation, or perhaps they're able to improve their physical exam skills, their critical thinking skills, their communication skills with the patient. Perhaps they're able to do things that are truly important for patient care, as opposed to, and again, not that some of those other administrative tasks are not important, but things that they really went to medical school for. I personally did not go to medical school to write notes, right? I went to medical school to take care of patients, and I'm hoping that these technologies will allow us to do that more. That's why I showed that slide at the beginning, as far as the intimate relationship between the patient and clinician. That's what a lot of my work is centered on.
No, yeah, that's exactly right, I think. It's like the diagnostic part of medicine. It's essentially you have like this piece of logic that you execute, right? Like it's, this input data comes in, I have this previous knowledge and I execute, there's an output. Now that seems like something that machines would be really good at. And I think a lot of people that go to most of my education was like learning that logic, right? But what you're describing is that like it's the human like sitting on the bedside, talking to people, which is unfortunately like we don't really get any education on at all. Is there an emphasis on recognizing that and like emphasizing teaching that a little bit more and like de-emphasizing that knowledge, logic, execution part?
Yeah. I think what happened, so I'll say here at the University of Michigan, Jen Stojan and the doctoring team, they do a great job teaching clinical skills and patient-centered communication and things like that. I think one of the challenges, and I feel fairly comfortable saying that this is the case just generally, students, they enter medical school, and it helps me because they have a very idealistic view of the world and what medicine is, which is great because it's inspiring. And then in medical school, they learn all these wonderful skills. But unfortunately, what happens is the realities of medicine sit in, or the hidden curriculum, as many people like to call it, which in some cases potentially gets in the way of actually building upon that foundation of skills of compassion that they may have learned in medical school, because there's so many other things that get in the way of establishing though or further developing those competencies, strengthening, solidifying them, but then also truly engaging with patients. There's so many things that get in the way of that. And again, I'm speaking broadly here, and I probably sound very idealistic, but my hope is that these technologies will sort of allow that hidden curriculum to go away, hidden curriculum meaning students learn a certain way in under or in UME or undergraduate or before they get to the wards, but then once they get to the wards, they realize that there's a different way of doing things because these are the realities of medicine, right? So my hope is that these technologies allow that hidden curriculum to not have as great of an effect, and they are actually able to, again, sit at the bedside, be with patients, to actually take care of patients, as opposed to for worrying too much about, did I get my note finished? You know, and again, I know that that's an important part of what we do, but I think it's too important right now, though. I think
Yeah.
it's more important in some respects than, you think about the EHR when that was developed. A lot of people say it was developed for billing purposes, right? Was it developed to bring patients and physicians closer to one another? I don't think so. Right. And I'll say too, if we're not careful, if physicians do not have a voice in development of these technologies with AI, the same thing can happen. If we are not aware, we'll see these technologies developed in ways that do not allow us to have that relationship with patients that we all seek to have.
Thank you for that. Um, I want to ask you a question for myself here. Honestly, I have to say, like my head keeps on spinning. I feel like I just I try to learn Claude. There is 3.7, there's 3. And then I try to learn that. There's GPT 4.5, and I try to learn that. Now there's Gemini multimodal. It's the pace of change is so fast. And I feel like overwhelmed with not being able to keep up. Do you have any advice on like how to a busy clinician can do? What can I do to keep up with this overwhelm of like, it seems like it's coming and changing
Yeah.
so fast?
So I'm going to say, at least for me, I know that it's fairly easier for me to sort of keep up with a lot of things that are going on because I'm in various communities. But believe it or not, I perceive you as being further ahead than many. Unfortunately, there are some that are not interacting with these technologies at all. And I've heard that, going to different places and giving talks and so on. So I think that is like just interacting with or engaging with the technologies is important. I think UMGPT, given some of the benefits of that, and that the data is not, it's everything's private. They're not looking at our prompts. They're not looking at our searches. The data isn't used to train them out. Given some of the benefits there, that's a great place to play around with the technology. Just play around with it is what I would suggest people do. You don't have to use Gemini and Claude and everything else that's out. There's so many. There's too many. Perplexity and all those. There's too many. I would say find one and play around with it. And one of the things that I like about the one for U of M is that it offers that security, in that you don't have to be as concerned about your data being used to train another model and so on and so on. And ultimately, eventually, this UMGPT, we're going to be able to enter, my understanding is that we'll be able to enter HIPAA, protected information there, right? So there are some benefits to just playing around with that technology, particularly, and I wouldn't say it's important for people to play around with like everything out there or to feel like they have to know everything out there.
I wanted to add for all those who are on the call who may not be physicians or clinicians, I actually did participate in, or I took two of those modules in your AMA, Data MD, in those courses. And as like a non-physician or clinical person, I still found them very valuable and very helpful. So just wanted to throw out a plug for everyone else that I would encourage you to explore those because they were they were understandable to me as someone who is not incredibly familiar with AI. So I definitely encourage people to take a look at those.
Well, thanks for that, Ashley. I appreciate it. I'm glad it was helpful.
Yeah.
Well, thank you so much for spending the time. This was so informative, and I'm really happy and lucky to have you as someone at Michigan that's advocating for this because it's really something that's, it's here. We have to get it, we have to adapt to it. So do do the modules that Cornelius put together, subscribe to one of these models and use them every day. I think those are the major 2 points at the end that I got.
Mhm.
And we hope to have you back very soon and to talk about next year what new things we have to think about. So thanks again, Cornelius, for spending time with us.
My pleasure. Take care and thank you for having me.
Thank
Bye.
you.